appreciate everybody coming today. I mean, um, it's nice that it's kind of a small, intimate group. So I've done plenty of workshops over the years. So if you guys have any questions right off the bat, I mean, it's not interrupt me anytime. I'm more than happy to answer questions. But my name is Dr. Brad Conder. I'm a physical therapist. I've been doing physical therapy for almost 20 years. I was spent about 5 years in Lexington. I went to UK, and then came to Louisville about 15 years ago. I've known Eric and Erica for many years now. They've been both fortunate to have me torture them at one time or another. So I don't think it was too bad. And we'll talk about some of those things later on as far as what we did too. So, but thanks for having me here. I appreciate it. I've got multiple years in different experience in different facilities. Right now I own a business. My business is Focused Physical Therapy. I have 2 outpatient clinics, one over off Blankenbaker and one at Melwood Arts Center. And I've worked in outpatient orthopedics mostly for my career. I'm board certified in orthopedics, and I've worked in hospitals. I've worked at Baptist East in their acute care. I've done home health with being. I do industrial experience. So here to hopefully help you guys a little bit, just learn a little bit about physical therapy in general, which a lot of you guys have probably already experienced some physical therapy, but we're going to go over some things. If you have questions, just let me know, because a lot of times you may not always know why we're making these decisions when you go to your therapist, or if you're trying to go to therapy somewhere else. All righty. So mostly what I kind of wanted to kind of start talking about today is just a little bit of just as far as what a physical therapist is looking at when we try to work with patients with Parkinson's. Some of the biggest things that we're going to do as far as assessments. So we'll go over that, and then we can kind of get into some specifics as far as orthopedics as well. This we were talking about earlier, as far as what his physical therapist does for him, some of the manual techniques that we have with our Parkinson's. So we'll talk about those as well. We'll talk about the role of a physical therapist, really what a physical therapist is trying to do when we have a referral for a Parkinson's patient. What are we really doing when they come in the door? What's one of the big things we want to look at and help them with? I also want to kind of give you guys some basic advice on the home exercise program. You may or may not need it. I just thought I'd bring it anyway, just because I know you guys are in a great group with Eric and Erica at Rocksteady. We kind of fit in really well with these type of groups, and we want to kind of work together. So I brought some stuff. I actually brought like a kind of a home exercise program that I would maybe give out to somebody that can do it on their own. So we can maybe demonstrate some of these. And if you want to have a copy of this, if you don't already have it, you can get it, but you might already have it. So we'll go over that. And then I wanted to maybe talk about some other things that might be available. Yeah, I actually brought this kind of device that I was telling Eric and Eric about, that I had another personal trainer I work with that invented it. And I've been using it recently for a lot of my patients that have balance issues or orthopedic issues. And just as an example, there's other things out there that could still help you. And, not necessarily need this device, but there's things out there, and we're always trying to invent more things to kind of be. So, but again, if you have questions at any time, standing up here, just kind of talking to their group, it could be and chill. So, okay, it's really appropriate to kind of go into a whole spiel of what Parkinson's is, because you guys could probably tell me more about it than I can tell you as far as the actual definition. So I thought that wasn't really appropriate to do. Yeah. But so what are we looking before at one time or another? They're all positive experiences for the most part. If you guys have any questions about any of that, like if we're going along, I'm talking, just let me know. I'd love to kind of talk about it as a group and kind of explain some of the stuff that we're looking at. So we as physical therapists, when we get a Parkinson's referral, I mean, we know one of our biggest goals is movement activation. That's what we're going to be looking at. We're going to be looking at kind of what your current state and your baseline of movement is, kind of how your extremities are moving, help you be able to transfer, help you be able to do those things. Those are the things that physical therapists are always going to be looking at right off the bat and have those goals in mind. I thought one of the things I would talk about today, just kind of because it's a little bit more of my expertise, is orthopedics as well, and how that fits in with Parkinson's. So does anyone here completely pain-free all the time? Did you say you were? No. Yeah. So obviously, I asked that question. I know most people are not going to be. When it comes to of your movement, your transfers, your walking, I was going to talk about some of the tests that we use as well that you guys can probably do on your own. But for me, I'm also trying to address pain and dysfunction that might be coming along with some of these conditions, because they're always going to be different with someone that maybe doesn't have a neurological condition versus someone that does, for different reasons too. So compensation, tightness, if you're not able to kind of have the normal movement you would have, some of these compensations that were really kind of set in as far as hamstring tightness or neck and back pain, knee pain, some of those things. So over some of the common conditions that I treat a lot, I always tell people physical therapists, we're kind of uniquely qualified, especially in Kentucky. I was telling Eric, physical therapists are actually, it kind of depends on what your practice act is as far as what we can do. So for example, for me, I feel like that as a physical therapist, I can do almost any manual technique that's ever been invented. I can do it. So I can do dry needling, I can do joint manipulation, I can do soft tissue work, I can do scraping, you can do joint mobilization, cupping, all those things that physical therapists can do therapy. And it always depends on the facility a little bit as far as what they're going to be able to offer to you, but you want to just have that open conversation with the physical therapist. I'm having knee pain that really, really hurts. It's going to limit what you want me to do as far as it's standing or walking, or even if you're taking part in group classes, the bit about some of those manual treatments. So has anybody ever had dry needling before? Have you heard of it? What'd you think? A good experience, or did it help?
Yeah, it was something that I went to before. It makes
Which is good. That's a purpose. Kind of get you to that good baseline and move you on. So has everybody else heard of dry needling? So what it is in Kentucky, physical therapists, people always ask me, what is it? It's kind of one of the newer manual techniques. Again, I can manipulate someone's spine. I can mobilize their spine. We can do soft tissue work. Massage therapists can do that, and physical therapists can do it. But dry needling is one of the newer manual techniques. It is the use of acupuncture needles to release trigger points, and basically. Now, people ask me all the time, like, what's the difference between acupuncture and dry needling? I was like, well, to me, the only similarity between acupuncture and dry needling is the needle itself. So it is an acupuncture needle. It's been around for a while. I've been doing it for about 15 years. It's been around much longer than that. It was kind of invented when physicians were doing EMG studies. If you know what EMG and nerve conduction studies are, where they put needles in your body to kind of see where the nerve connection is interrupted, if you have a nerve condition. And so when they were doing these many, many years ago, they started seeing people just having muscle twitches and relief of pain just from doing the needles in their body. So they kind of started to experiment with it. And then they took some principles from acupuncture. And so you have doctors and physical therapists and sometimes chiropractors now that started to kind of use these to kind of actually manage pain. Now, the main functions of Kentucky can do it. So what I wanted to condition, oftentimes if you have a muscle condition that's like, say, neck pain or back pain or knee pain or say elbow pain, I actually needle myself a little bit every once in a while because I get some tennis elbow from playing really bad golf. So I'll needle myself. And so what it does, so I feel like a little trigger point, like right here in my muscle, and you put the needle into the muscle, and it actually has this what we call local twitch response. So the muscle will literally kind of twitch and release on its own. What we've discovered with that kind of treatment technique is that not only is it a pain reliever, but it also can kind of help muscle activation. One of the goals of the therapist, if we're trying to get people to walk better or move better or just have their motivation versus muscle strengthening, those are two different things. So in the course of like having an orthopedic problem, we know from research that let's use knee, for example. If you have knee injury, whether it's surgery or whether it's trauma or anything like that, we know for a fact that this muscle will shut off by 25% immediately. It's not that it's weak anymore. It's just the nerve signal from the brain to your spinal cord to that muscle shuts off 25% of the muscle fibers like right away. So one of the things that we can do with dry needling and some other things is we can put the needles into the muscle, get the trigger point release for pain relief. We can make those muscles actually fire again. Did I do dry needling with stem on it for you? Yeah. So we put like little, I literally put alligator clips on it like you're being hooked up to like some jumper cables. And I put the stem on it and it kind of will start to make the muscles fire. And so it can give you some muscle activation. We also have a lot of research that can reset the chronic pain loop as well. If you've had pain over a month or two, technically you fall in this chronic pain realm. And what we've learned from chronic pain is that your brain processes from your pain area to your brain kind of get stuck open, and we need to reset those. And so we want to use our manual techniques, especially dry needling, kind of reset that so we can tell the body it's okay not to have pain. It's okay to kind of do whatever function that we're trying to do. So, but does anybody have any questions about that as far as dry needling? Eric wanted me to cover that. I thought it was kind of cool to kind of something new out there. Yes, sir. Good question. So the question was, if we do dry needling for any type of condition, like pain condition or muscle activation condition, how long does it last? That's one of the reasons why I use it actually, is because I feel like whatever I'm straightening, let's say tennis elbow, I can scrape it, I can do massage, I can do some mobilization, we can do exercises and stretches. I feel like dry needling actually has a little bit more lasting effect than some of the other things. I think it's because of that neurological resetting that we're looking for. So you may have experienced that too. I think it kind of gets you there maybe a little bit faster and carries over a little bit more. And the one thing I'll say with that is that this is something that I cover a lot with my patients. Any condition that I see in my clinic, you don't cure it, like ever, right? So, and really in medical care, there's not too many conditions here you cure. But what we're trying to look for is the best management of it. And so to give you all the techniques we can possibly know to kind of manage it, get you to a good baseline to kind of keep you to be better on your own. So to go back to your question, I do find that people have like some type of pain condition where massage has helped out, or even helped out, the dry needling does seem to help it get better a little bit faster and maybe last a little bit longer as well. And the reason I think it does that is I think it gets you to that baseline of pain-free a little bit quicker. And so you can actually take advantage of the good work you're doing for exercise and stretching and your classes. You get more out of that because you're managing those conditions better. Does that answer your question? Yeah. So let's say if I was to massage your muscles and it felt good for a day or two, it might last for 3 or 4 more days. So it's something it's kind of, it also is individual as well. I've had some people where I needle it one time and it gets way better and stays better right away, or it takes like 3 or 4 sessions to kind of last longer. So yeah, I wish it was the type of that. If dry needling was more like needling once and get 3 months, I'd have a line out the door. That'd be awesome though.
Will get really tight, all the muscles back there. Or in just one session, it gets better, it lasts. Until you just start overusing it again and it cranks back up. But it lasts and it releases it. Don't release. Even with the needle, it's such a small needle. A lot of people think it's very painful, but it's not. It's a different feeling. Your muscles twitching. It's almost point where he was even tapping on step more. Your muscle is voluntarily twitching, but afterwards, it feels great.
It can be pretty achy and sore. Yeah. People ask me all the time, is it painful? Like, well, they kind of train us not to use the word pain. You don't kind of put the pain in your brain like it's going to hurt, but it can be pretty achy. But I find the result as far as that achiness and that. So, yes, ma'am. Denise. So, so are you talking about pain stimulators that actually have wires that go to the spinal cord or just to the brain? Yeah. So only thing. Yeah. Yeah. So you're fine. So we're only worried about hitting hardware in that case. So like, we're not going to be needing your brain, right? So, but it's a good question. It's not going to interrupt. It's not like we're kind of, again, having an implanted type of device that actually literally kind of touching spinal cord or midbrain or anything like that. So it's more of just like stimulating the nervous system from a mechanical way. It's still technically external, even though the needle is interned into your muscle. It's still external from the nervous system itself. That's a good question. So our question was just to review that. Can someone with like a brain stimulator or some type of thing that your physical therapist would review and know on your medical history of what you're doing? The only caveat might be like if you had the brain stimulator like put in like Monday, they usually want for any type of surgery at all. We try to not do any dry needling for 8 weeks, and that's just infection precaution. Because of how things are. It's just so for the needling, like I said, I pulled out one of my needles. You may or may not be able to even see it. So it's so small. This is one of the smallest ones I have, an acupuncture needle. So and even for this, I would kind of all the way into the and actually sometimes I can kind of demonstrate it, but if we're doing kind of, we got to get it all the way down deep into it. So and it's pretty achy. Yeah. So no, not at all. No. Yeah. Actually, what's ironic is, I do a lot of headaches, chronic headaches, and suboccipital areas in the neck that can be a trigger for migraines. Because migraines and neck headaches are different. If people have had Botox for headaches, I've actually feel like that this is a good application of that. I feel like that it does usually help. I've actually have tried to do some dry needling on some different neurological diseases myself, and it's varying help. I have a couple people right now that have drop foot due to stroke and due to just having a back problem, and it's doing really well. And so I'll put like the drop foot, I'll put all the needles in the lower leg and I'll put them on the stem. I don't use stem for everything. Some you may not have stem either. I just do the dry needling can be for trigger point release and pain relief, but if I'm trying to get muscle activation, I put it on her leg and I can immediately see their foot just kind of pop up. And so I can do that. Say what? Oh, toe curling? Can it help with that? Possibly, yeah, possibly. I mean, and so the ones that I've seen that kind of have a little bit more spasticity to muscle groups, like I've tried to do some cerebral palsy that have like that spasticity. I saw some improvement. Again, it's a little bit different though, because in the case of say like we just have knee pain or like even a drop foot, we can address that there, but in the case of cerebral palsy, it is kind of a central brain issue, so we're not going to train that per se. The same thing with even Parkinson's. We're not going to cure maybe the underlying reasons of it, but we're trying to help the external parts of it. And so, in your case, I think it's probably low risk to do it, and that's what I would tell people because anything so much more meant for, and we use it so much for pain relief right now. The ones I've tried, it's low risk. It's not going to make you worse. And you just talk to your physical therapist and see if they can do it. Most physical therapy places in town, at least in Kentucky, do it now. Not all, but most of them do. And there's varying ranges of experience as well. So I've been doing it over 15 years, and I feel like the company I used to be with were one of the first ones to do it in town. But once we started doing it, everybody started doing it. So there's varying experiences with it. Did I answer your question? Yeah. You don't have to. Well, Erica, what do you think?
it helped me a lot. I didn't say I had surgery. So, did it.
Yeah. Yeah. So to answer your question, I think sometimes that you might want to dive into that question a little bit more. Physical therapist, like what are you going for? So if like even with treating people with Parkinson's or neurological conditions, I mean, that's why I mentioned that earlier. You don't cure things possibly. Now we're just kind of going over other things that might get you a little bit better what you're going for. I think in the case of dystonia, I think if you're having individual like pain areas, or if you're having individual areas that won't activate correctly, say like a deep hip muscle or like a quad or some things like that, I think that can be another treatment option to kind of get you a little bit more improvement. And that way you get more out of what you're already kind of doing. So I think the answer is yes-ish. So it's not going to cure the condition, but it can maybe, because that condition gives you so many different orthopedic and kind of musculoskeletal issues, I think it's just another great tool to kind of help manage it. And like I said, worst case scenario, it's usually not going to make you worse. It's just like, okay, does this work for me? What are the things that we have? And that's kind of what I want even like talk about this. I mean, or just some different options for you in physical therapy. And that's kind of what we're always trying to do is just evaluate where you're at and continue to go over all the different options for you to kind of meet your goals. So great question. That's one of the reasons why we call it dry needling. When they first invented it, you know, physical therapists wanted to kind of be clear on what we were doing. So when you have any type of medication, say like a cortisone or a vaccine or getting an antibiotic or whatever it might be, those are called bore needles. So they have like, they're bored out. So they have like something you can shoot stuff through. But we call it dry needling because it's not capable of delivering any type of medication. It's just purely a needle by itself. It's not bore. It's just a small needle. It's so small actually that, you know, I didn't bruise, I didn't bleed. They even teaches that it's so small that the acupuncture needles actually push the skin cells apart. They don't actually tear the skin cells. And so typically you don't bleed unless you hit a vein. And sometimes you'll hit veins, but they're just superficial, little bruises or whatever. That's a precaution sometimes with dry needling is if you're on blood thinners, but it's a precaution. You just want to kind of make sure your therapist knows about it so they can try to avoid doing that. So. Well, that's how we kind of discovered it. They were doing nerve conduction. The physicians were doing nerve conduction studies, and they're like, they use the same typical needles, they're a little bit bigger and longer typically. So say if you have carpal tunnel, they're going to put like needles all the way down your upper extremity and put electrodes to see where the interruption of the nerve is. And so they were anecdotally, they were seeing changes in muscle twitches and pain. And so we started to kind of investigate it more and actually develop a treatment style out of just doing needles into trigger points. So, yeah.
I was in a nerve conduction study before I was diagnosed with Parkinson's.
Mm-hmm.
And it was Dr. Mark Brown, and there, and they did the EMG first. Tech came in with that. Everything with the nerve conduction study.
Yeah.
So have you ever had needles stuck in your ass? So he said, that's what we're going to do. We had a doctor training, so talk through the whole process.
Yeah.
But when he stuck it back there in my thigh, I almost jumped off the table.
Yeah.
And he screamed. I could not believe how painful that was.
Yeah.
And all he said was, "Oh, wait,
Well, see, that's different though. So their goal is different. Their goal is to kind of get close to the nervous system, and they are going typically a little bit more aggressively and deeper. I mean, we go deep as well because we can go to the bone, but typically, and how I do it, I mean, like even here, I'm trying to go to just the area you need it and kind of get in and get out. Now, again, you're going to have achiness from it, but I mean, you can have some significant kind of experiences out of that. Yeah, and I usually find that people that have had those studies say that dry needling is way less discomfort than doing those studies. I mean, a whole different purpose too, you know. So it depends. So if I'm just kind of like, if I have a trigger point here, I'm just trying to release it, I'll kind of actually go in and out and get like a nerve release or not a muscle release, and I'll just stop. You know, massage it and scrape it and kind of go over my, or like if they have a chronic back problem that I love to do it on, I'll put the needles in and put the stem on them. You can leave it on for a couple minutes, up to 30 minutes. It just kind of depends on what we're trying to go for. So, yeah. So like even in the case of your toes, if they found the right muscles and put it in there, they could turn it on and kind of get some reaction, and kind of, especially in the case of say spasticity and kind of muscles that are kind of chronically neurologically tight. Even before dry needling, we were taught to do this in school, where we put pads on for E-stem or Russian and neuromuscular stem. And the purpose was to turn it on for so long that the muscle would get so fatigued it had no choice but to relax. And so you can do that as well. So like if you had a chronically tight muscle and you just want to release it, they put it in and fatigue it so much it would have to release. That's a technique and a purpose. So, yes, ma'am. Say what now? So her question is it mainly for pain? Now, in the medical world, it is mostly used for pain relief. That's why there are other functions for it. So was your question about balance? So if I was looking at, and I have a couple of people right now, different devices, like this device for balance and some other things for balance. If I was to evaluate them, and that's one of the things that's kind of one thing I forgot to talk about today. A physical therapist's primary job should be to do your assessment and evaluation of where your problems are. Because, and I was talking to Eric, I mean, in a perfect medical world where we didn't have any insurance and payment issues and restrictions on just where you get your treatment done, having a physical therapist, athletic trainer, personal trainer, massage therapist, they all kind of work in conjunction. But the physical therapist role should be the ability to kind of assess and evaluate diagnose the problem. So in case of balance, if you have a weak muscle that we need to evaluate and figure what that is, say in your hips or in your ankles, say if your rotators of your hip weren't activating, we could needle those muscles and try to activate them better so you're getting more out of your home exercise program and your group classes. So it could be. Again, I don't want to kind of make grand kind of promises because there's just so much work to still be done. Even though dry needling is kind of cool and been around for a little while, it's still relatively young. I mean, it's not like it's been around for 100 years or anything. So again, from the good thing about physical therapy and things we're doing, it's low risk. I mean, it's not shouldn't make your balance worse, but could it help you? It could possibly help because of just the muscles that might be actually causing some of the problems as far as actual weakness. But then you also have to address still the neurological part of Parkinson's as well. You know, the activation and being able to get the muscles to fire in the right timing. So, good question. Talked a lot about dry needling. I didn't expect to go down that rabbit hole, but that was great though. So, any other questions about that? Cool. Let's see. Let's see if I can get back. So, just to kind of finish up with that. So some of the orthopedic issues I've kind of commonly have seen with treating people with different neurological. I mean, knee pain is a big one typically. Usually a lot of neck as well, just because of the postural strain. The neck and head is kind of important to kind of take care of if you can, just because that's kind of where your balance kind of starts. You know, I've even, when I was going through my physical therapy training in school, so you're supposed to do pediatrics. I was sometimes get into. I went into orthopedics just because there wasn't any jobs, but I worked really closely with OTs, and OTs would actually kind of argue that most of your core activation starts from your neck and your oral motor complex. So making sure to kind of take care of any neck problems is usually very helpful as well. So you can have full motion. One of my guys I'm working with balance right now, he didn't really address any neck problems. This is how much motion he has. As that and this. So even if you had full use of your legs, if you don't have enough motion to kind of actually turn your head to do those things, it can really limit you and kind of be a big fall risk. So if you're trying to kind of navigate your house as far as moving from one room to the next, stepping off curves, doing stairs, having good neck mobility and movement is super important, and trying to work on that postural ability. So those are the things kind of some orthopedic issues. And like I say, if you're not getting them addressed, I mean, that's something a physical therapist could do as far as manipulation. I know a lot of times joints are the big issue in that case, not always the muscle. So if we had dry needling for the neck pain, and for this guy, I'm actually literally mobilizing his neck Physical therapists mobilize more. You know, chiropractors usually do adjustments, but we call them mobilizations, where we're kind of real gently moving the bones. Because in this guy's case, he's got severe arthritis in his neck, so his muscles aren't the problem. It's like he literally can't do it because the joints are stuck. So I just go in there and I kind of push on him. And I kind of, you know, manually move his neck. So we've gotten him to about 25% more, and so even just that improved his balance because he can actually move his head to kind of improve. Because when you're having balance problems, it's a factual thing as far as why that's there. I mean, part of it's the muscle activation of your body, part of it's the weakness of your body, but also your vestibular system as far as your inner ear, but also your eyes and your neck and how that can move. And if you don't have enough visual input, sometimes that can kind of limit some of your balance too. So, and balance and fall risk. So that's another thing. The next thing I was going to talk about. I'm sure you guys have talked to a lot of your practitioners and your physical therapists about balance and falls. Has anyone done any kind of like testing to kind of see kind of if you're improving your balance or falls at all? You know what I'm talking about? So some of the biggest assessments that physical therapists use is stuff you can do on your own as well. See if we can make any kind of baseline measurements and then improvements. Single leg balance is always going to be huge. So they've shown a really, actually, this is for all population, not just for Parkinson's, but they've shown in research for single leg balance, direct correlation between your mortality and how much you can stand on one leg. A lot of that extrapolation is due to, we know if you have a fall and you break something, what tends to happen after that, right? So you can easily do this at home, but make sure you're safe. Make sure you have somebody with you. Maybe even do it. Maybe Eric and them can do it. Maybe as an assessment one day. Like literally start to test how well you can stand on one leg. If you can have a goal to kind of get over 10 seconds, that's usually really decreases your risk of falls. And that's something that I get my patients to kind of, once we get ready of it, I'll come at a countertop or somewhere safe or somebody to watch them, especially if they really struggle with balance. Kind of just test that to kind of try to work on it. I mean, are you ever going to be able to get to 2 minutes of this? Maybe not, but just something to kind of test and kind of work on consistently will be helpful to kind of see where your balance is. Other tests that we do in physical therapy is what we call a timed up and go test. Have you guys heard of the tug? Yeah, for the most part. It's a pretty easy test, but again, we're just getting baselines in therapy because sometimes in therapy we have to do these baselines because otherwise Medicare will kind of kick everything out. But so they want us to do these tests. So basically, like even where Eric's sitting right now, so it's really simple. I'm going to try to do it without holding your hands. You literally stand up, walk. It's 6 meters, I think it's 6 meters. It'd probably be about the distance for this table. You stand up, you walk, and you go back, and you just time it. It's called timed up and go. There's a lot of research and showing that if you can improve that, also decreases your balance risk. So it's something you can do as well to kind of see if you can get that better. The goal is to not have to use any chair handholds to kind of get up. If you have to, you have to. But eventually to see if you can stand up on your own, walk there and back. That's another test. The other ones we would sometimes do too is just seeing if people can stand in tandem. So what that means is like, can you literally stand like this? Right? It's just a balance test just to kind of see where you're at and see if you can do it. It's all kind of meant to kind of see if we can decrease the risk of falls just based on your everyday life and moving around your house and things that you might have to do, lateral movements, backwards movements. And so those are some of the big tests that we would usually do in therapy to kind of see where your baseline is. Yeah, perfect. Yeah. You ever taken out your eyes?
Yes.
Yeah, perfect. Yeah. Talking about resources, and we're going to talk about that here in a little bit too. You know, physical therapy, the role of physical therapy is to help manage, to get you a baseline, give you some testing, maybe help you with exercise as well. And some places do all the exercise for you, or having a group like Roxley, I think is just awesome. At least in my practice, I was telling Eric earlier, when I'm seeing patients, and my setup's a little bit different. I don't need to watch you do 5,000 leg raises. That's not really something I need to do for you guys. So oftentimes I love partnering with places like Eric, and they have so much good experience to know that we can do the repetition. They have good knowledge of basic physical therapy, kind of exercise that are common, and you guys are doing a great job with that. So keep it up. And I love that you have that resource. Let's see. Any questions moving forward? Good. What's your time like? always talk much longer than I think. I did want to kind of talk about this, and again, we can probably gloss over it possibly. I brought like anybody heard of like the big exercises, the big and loud? So they already know it, and you're probably already doing it. We can go over it if you want to, or if you don't, we can go over. But I just printed off some of these. If you guys want to have on your own, or if you guys already have them, that's great. I'll get your all the emails, and you reach out to Eric and Erica. I brought these in case everybody wants to look at them. I can just kind of pass them around. You guys can take a look at them, see if you're already doing them. I didn't invent big, but also it just had kind of a premise, big movements to try to activate certain parts of the brain to kind of hopefully get better activation. So you guys can take a look at that and see if you'd like to have that print out. Like I said, I'll give it to you for free, so I can email it to you. You can have it and print it off. So, yeah. 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 So where are you out? Yeah. Yeah. What was that group called again? Delayed disease, and so Zoom. Evansville, Indiana. Can people Google it on their own? I'm just trying to say it online for the video. Okay. Awesome. That's cool. It's awesome you guys have so many resources. And that's probably the one thing I want to kind of reiterate for you guys. I mean, it's awesome for Erica and Eric to bring me in. They're great resources. They have a wealth of knowledge. Just you guys have in this community. I know it can be very kind of a daunting task to kind of do the work you need to do, but it is a lot of work. But having those resources and doing it over and over again, we're trying to gain quality of life and make sure you guys can enjoy it. And it sounds like they make it really fun too, which is awesome. So get more people in the community is going to be very helpful. Let's see. I think it's really kind of mostly what I had to talk about today. Is anything else that I missed? Oh, access to physical therapy. We want to talk about access to physical therapy. Say what? Yeah, I can demonstrate this real quick. I can kind of put it on while I'm talking. So this is just, and the reason I wanted to bring this in, and again, nobody needs to have this, but I was thinking like again, for my personal practice, I'm thinking when I'm having people that have conditions like Parkinson's or difficult conditions, I want to make sure to give them all the options possible. And my main encouragement was just to continue to kind of seek out new things. I could probably even get Chris to give you one at your place, or at least let you borrow one if people want to try it. Yeah. Yeah, it's postural, and we can try it out here too once we stop. If we want to try it on, we can kind of see the before and after. I got videos on it as well. But while I'm putting this on, I just want to kind of talk a little bit about the access to physical therapy. And this is something that people don't always kind of know exactly what's how to access physical therapy, and it varies from state to state. So Eric and I were talking before. Physical therapy does kind of the access to it can vary from state to state. In Kentucky, have one of the best practice acts there is as far as physical therapy. So what that means is that we can do dry needling, we can do muscle activation, we can do muscle manipulation or joint manipulation, we can do direct access. And so what direct access means is for a long, long time, physical therapy, the only way to go to physical therapy was you had to get a prescription for it. But in the state of Kentucky, you don't really have to do that to go to get a prescription for physical therapy. So you can access it directly. So if you know you have a problem, whether it be from Parkinson's or pain problems, I mean, you can literally just Google physical therapy and go wherever you want. Now, the only caveat might be more of like actual payment structure. Like I said, it does matter with that a little bit. You know, most managed care like Anthem, United, stuff like that, you can go to physical therapy, it won't at all. Of course, there's always self-pay options as well, where you can just pay. That's usually something that I usually recommend to parents. You'd be surprised at the resources that are out there that might actually be cheaper, especially as deductibles and things change over time. So Kentucky is really nice about that as far as being able to do all these doing all these treatment techniques and being able to test them without having a prescription. And plus we can do, it's a little bit different since we're right across the river. Indiana, you have to, you can go without a prescription, but you have to get a prescription after 30 days. But typically whatever facility you're going to, they'll take care of that for you because you usually have a doctor and somebody we can reach out to for you. So does anybody have any questions about how to access physical therapy? I mean, a lot of you guys already have, so you probably don't have questions about that. Yes, sir. Yeah. Well, that's all due to payer source. That's the hard part about it. Like I said, if we just go straight, if we kind of talk about it in the context of no payer source in this state law, you can do whatever you want. But especially like if you wanted both those things, if you weren't going through Medicare or is it Medicare or Medicaid or it wouldn't matter. But Medicare is what matters. That's the only reason they have those laws in place. I mean, even like outpatient orthopedics, if somebody was going to two different, like going to court and me or pro rehab all at the same time, they wouldn't pay for all three of them. It's just one. So that's just kind of how that's all payment structure. I'm sorry to say. Self-pay, you can do what you want. Yeah. So, and the one thing I'd say about that, and this is just kind of I wouldn't say it's a plug, but insurance my clinic period. And the reason I don't is because all my sessions are only one to do that with insurance and the payments. And I've tried to kind of just advocate to people that healthcare is changing really fast. It's going to continue to change. I feel like health insurance will continue to get worse as far as like what they pay for, who they allow to get paid, their deductibles, co-insurance. So my only what I've been advocating to people is just ask questions. It doesn't matter if it's hospital or whatever. Ask them about your bills. Ask them how much it's going to cost up front. If they don't give you an answer of upfront cost, then they're either lying to you or they have a major problem with it. They should know in general what they're going to charge for everything they're doing. And also negotiate. I mean, like you can negotiate even with hospitals. Like you have a big bill and call them like, well, I got $200 and they're like, okay, we'll take it. So it's the little plug there as far as healthcare changes over time. So just be aware that just you can start asking questions about your insurance. You can ask your insurance directly and your providers as far as different options for you to get what you want. So I know it's a little weird, but this is kind of the healthcare world we're in. Yeah, which is good. And so that's why, like even me being, I mean, I don't know. Like you said, I treat more of like 50-year-olds that kind of have chronic back pain. So, and I'm not a fit for everybody. And I just tell people that open. I can't, it's okay too. And I'll make sure to fit them up where they can use your insurance. Cause that's, you have to use your insurance sometimes and that's okay. And if you have it all paid for, I would definitely recommend keep doing that. But I would say that's a restriction of why they won't pay for that. They won't do it. That's just the Medicare laws. So. Yeah. Yeah. And the weird part about that is all the coding kind of works the same, like OTs, PTs, and actually chiropractors sometimes use the same codes. And so when it's going through the system, I don't care if you're OT PT. It's like, well, you're using the same code, so I wish it wasn't so convoluted.
About their quote too.
Yeah.
Because there's other quotes they use.
Yeah.
To kind of get around that. It's nothing legal, but it's just a therapy.
It look weird.
Using those same codes all the time. I think they just get ingrained in those codes.
Mm-hmm.
If they could really use a different code, and then insurance pay for it. But if they use the same one, then they won't pay for it. It's so weird.
So this is a demonstration of this device. It's called a NeuroPack. A friend of mine invented this. He took the idea from some other devices they wanted to make mobile. Is not great, and so he wanted the military to be able to wear this, get strengthening, get some core strengthening, and then actually be able to still do their PT that they do in the military. We started to kind of do it to different things. And the only reason I brought this, again, nobody has to have this or use it, but I just want to give an example of things that are out there, because there's different devices in this out there too that you could possibly use or different. Like I said, we could possibly even let them demo at Rocksteady, and I'll hook you up with Chris, because he's letting me demo this too. He's letting me demo this because I'm trying to help him create protocols and how to do it. It's really whatever exercise you're doing, you just add it to it. And so most of the success I've seen, and again, once the video is over, some people want to try it. So the basic premise to this to me is that it's a good, helps your posture. It's going to get a little bit of core activation because it's forcing you to kind of have a back support, and it's kind of having the direct pull from your back and core down to your legs and through your feet. So when you're starting to do different motions, you're going to feel different parts of your body activate naturally just while you're doing walking, or if you're doing balance training or whatever it might be. So he just recently added in the foot part, which has helped me a lot with my drop foot guys, so he can actually do the movement and actually clear his foot to kind of walk better, so he didn't have so much pain. And then we don't have to have the arm part. Depends on if you have any arm issues, or if we're trying to work on specific things. It's actually what this does is almost feel a complete additional load to my core right when I put that on, as far as having that there. So we can still do all of our walking, any of our other exercises that we want to do with this. So we can demonstrate later on, but I just want to give you guys examples. Just don't give up on if you're other things that are out there, Rocksteady, other devices that might help you to kind of exercise and feel good. So yeah.
Is there a tension adjustment on that?
You can adjust the tension. I think he has like adjustments in the back that we can move it up and down for the tension. Most people just stay at the same one just because they can tolerate it, but we can make it harder. And also they have different sizes for kids and for bigger adults as well. So, but early stages, he's done some research session with this particular device. Like I said, there's other ones out there. I just want to bring it and let you guys try it after we get the video done if you want to. If anybody wants to try, you don't have to, but maybe we can hook Eric up with a couple of devices as well. So.
You guys might have noticed in Rocksteady before, if you guys have ever seen them pull out either after class or in their core class, big board with the it's based off that, and that is it's made of the portable.
Yeah.
So that's pretty much what it is.
Now this is super light. It's like, I think his goal was get this under a pound. So I think it's under a pound, but it's still very, very, it's like, it was made of carbon fiber, and it's got the internal components as far as all the pulleys. And all right, I think that's all I have for today. Open Q&A right now. If you guys want to talk about other stuff, hopefully, did I give everybody some information today, and was it helpful to be here? I was worried maybe I wouldn't give you guys stuff you haven't heard before, but hopefully it was a good session. I think we didn't dry needling the most, but that's okay though. So whatever you guys need to kind of be better and get the questions and answers you need.
And if there were any self-help techniques
As it relates to pain or like movement. Movement wise, I'd say that's why I kind of put this out there. I think you guys need to stick to what you're doing with Rocksteady and with your home exercise program.